So someone wanted to know how we treat monocular diplopia in neuro-op. And the first thing I'll say is most neuro-ophthalmologists do not want to treat monocular diplopia. So binocular means it goes away if you cover either eye. That usually is neuro-ophthalmology. But monocular means if you cover either eye, it's still there. And if you cover the eye that's unaffected, it'll be in that affected eye. And if you cover the affected eye, it'll be gone. And so monocular diplopia usually means there's something wrong with the media. And so the media things that we worry about are, of course, the cornea, starting with the tear film. Dry eye is probably our number one cause. Some sort of corneal opacity or irregularity in the shape, irregular astigmatism, keratoconus, corneal scars. Lens, cataract would be the most common, and then sometimes it's the retina. However, rarely you have monocular diplopia from cortical lesions, that is cerebral polyopia, where you see multiple of the image, and that's a cerebral thing, and that can be mistaken for monocular, albeit bilateral monocular diplopia. However, in monocular diplopia patients, usually their second image is a ghost image superimposed on the first image. And if you use a pinhole, the pinhole will block the rays except for the center one. And so the pinhole is a very useful tool for elucidating whether someone has monocular diplopia or not. So what are the treatments? Treat the dry eye with tears, and we ask them to keep a diary of this. I usually give them a home pinhole to try, because if it's intermittent and not present, they put the pinhole up. If it makes it go away, I tell them, you don't have to call me anymore. No, usually I tell them that that's not neuro-op, and we send them to the anterior segment. You've got corneal lesions, and you could have cataract extraction. You need to do OCT of the macula to make sure it's not the retina and look at the macula. And if we want to determine if the person has an organic cause of the monocular diplopia, you can do the wavefront analysis. So as you know, the wavefront, light is a wave, and so that wavefront can be determined by having a reference mirror determine the difference between what wavefront went in and what wavefront came back out, and that difference could be monocular diplopia. And so those are higher order aberrations, The lower order aberrations like spherical refractive error and regular astigmatism can be corrected with spectacles or contact lenses. Irregular astigmatism sometimes responds to a rigid gas permeable lens if it's the cornea. And if it's not the cornea and it's a higher order aberration, you might still take out the lens. Cataract extraction. And so monocular diplopia can sometimes be sorted with the wavefront analysis. In any event, monocular diplopia, either bilateral or unilateral, probably not neuro-op. You're going to use the pinhole to confirm it's refractive. You're going to look at the cornea, the slit lamp, the tear film, the lens, and the retina, and use a pinhole, and then the wavefront analysis. Treat the lower order aberrations with spectacles and contact lenses, and the higher order aberration might respond to surgery, refractive surgery, or cataract extraction.